This presentation is on a late presentation of hemoglobin SC disease. This topic was chosen due to the historically understudied and undertreated nature of hemoglobin SC disease, despite being the second most common type of sickle cell disease. So we reported the case of a middle-aged female that was incidentally found to have hemoglobin SC disease presenting as chest and back pain. So this is a 51-year-old female originally from Jamaica without any past medical history who presented for 3 days of worsening back and chest pain. Initial workup for acute coronary syndrome was ruled out with serial negative troponins and normal echocardiogram. Chest x-ray on admission was unremarkable. CT imaging, including the lumbar spine and the abdomen and pelvis, revealed marked splenomegaly and bilateral femoral head avascular necrosis. And significant laboratory findings included microcytic anemia with a hemoglobin of 8.9 and thrombocytopenia with a platelet count of 93. Because of these imaging and laboratory findings, an infectious and hematological workup was done. Infectious disease and hematology were consulted, and testing for EBV, Epstein-Barr virus, malaria, brucella, schistosoma, tuberculosis, HIV, toxoplasma, CMV, hepatitis were all negative. For the hematological workup, the peripheral blood smear showed target cells and thrombocytopenia. There was low haptoglobin, elevated LDH, mildly elevated indirect bilirubin, reticulocytosis, negative direct antiglobulin test, normal iron panel, and normal liver function. Hemoglobin electrophoresis at this point was obtained and showed a hemoglobin SC disease with approximately 48% hemoglobin C and 46% hemoglobin S. There was only 1.3% hemoglobin A. So this patient was presumed to have a vaso-occlusive pain crisis secondary to hemoglobin SC disease and was thus treated with IV fluids, opioids, NSAIDs, which resolved her symptoms. So the big takeaway from this case is that diagnosis at hemoglobin SC at age 51 is uncommon, but it is not surprising given likely missed early detection, which could have been secondary to lack of universal newborn screening at the time of this patient's birth, since where she was born in Jamaica, universal newborn screening was not expanded until the mid-1990s. Alternatively, there is a possibility she was screened. However, due to the historical connotation of hemoglobin SC being a milder disease, she may have not been treated, or, the disease was not known to her. So research now shows that hemoglobin SC disease does have higher rates of depression, splenomegaly, and retinopathy compared to sickle cell disease, and it can have prevention of potential complications with hydroxyurea and folic acid, just like hemoglobin SS disease. So this case highlights the importance of looking at the comprehensive evaluation of atypical findings in typical presentations like chest and back pain, and to always keep this diagnosis in the back of your mind in these at-risk populations.